Okay, let's start. We were discussing the drugs used for angina and MI. For stable angina, pain can relieve by rest and we just use nitrate. Okay. And next, you must advise to patient control your blood pressure, control your diabetes, and if have high level of LDL, you also must control. Okay. So you can advise these drugs too if the patient is hypertensive or diabetic, quit smoking. This advice you also can say make exercise in your lifestyle as regular habit. Must do exercise. Okay, every day, daily 30 minutes or 1 hour at least 30 minutes walk every day. These things you can advise to patient if patient have obesity, reduce the weight. And these advice. Okay, and for principal angina. It's because of emotional stress, we can give calcium channel blockers. Okay, the drug of choice. For unstable angina, very similar to MI, so we give beta blocker, calcium channel blocker, nitrate. If the pain is still not going, very strong painkiller, you can use the market here. Okay. So the treatment plan, because these two things very similar, you perform the ECG. You already know the ECG changes the same for STEMI, non-STEMI, okay, for non-STEMI and unstable angina. So if the patient is diagnosed with, from the lab is confirmed patient have MI, then we must give anticoagulant, okay, streptokinase, warfarin, heparin, anticoagulant we start IV. Anticoagulant, we must give intravenous, we must break that thrombus, okay? We break that emboli, blocking the artery completely. Understand? The other thing the same, beta blocker, calcium blocker, and nitrate and morphine. If the patient, like the same patient, I already explained the feature here. If the patient having here ST elevation, same feature, pain, same pain, severe pain, rest not relief, nitroglycerin not relief, okay? The patient have nausea, vomiting, all these things, and also having ST segment elevation. If ST segment elevation in ECG and patient have all these features, then no need wait, just rush, not thinking about this MI or angina. This MI or angina, it's a poorly 100% MI, you must go for as soon as possible. The first important thing here, pulmonary cutaneous intervention. It's mean to put a catheter inside the artery and break that clot. It's just our first option, okay? The gold standard treatment here for STEMI, for the STEMI. If the time is not much, if you, for example, you are late now, the time 30 minutes gone or 90 minutes gone, yeah. If the time within 90 minutes or 30 minutes in hospital, patient still have breathing, patient is still okay, and if the time is gone, then is useless. Then PCI is useless. Already muscle gone because 30 minutes is the maximum time to prevent the myocardium. Clear? 30 minutes is the maximum time to prevent the myocardium. If myocardium already undergo necrosis, okay, if already undergo necrosis and then it's useless to PCI. If the time is gone, or another thing, if you late, yeah, the patient still breathing, you are late now, you're not arriving hospital on time, the patient have chest pain, very severe, all the features there. One thing, you are late, okay, one thing you are late. The ECG performed. The time is already gone. One thing. Another thing that facility is all doctor, all cardiologists not perform this. All even heart doctors all can't perform this. Very cardiologists, very specialist about the PCI can perform this. If the a small setup, small clinic, yeah, it's not a big hospital, not have all facilities there. Understand? Not have all facilities there, then maybe not have this facility for PCI. PCI is just we put catheter inside the artery and break that clot. Okay, it's a percutaneous coronary intervention. Percutaneous mean below the skin. Coronary intervention. Intervention mean to intervene something, to add something. Okay, intervention. So our first option for STEMI PCI. If this is not available or if you are late, okay, already myocardium die, already myocardium necrosis start, then again go for the same thing anticoagulant. For STEMI, no PCI. For non-STEMI, no PCI, just anticoagulant. This is the difference between two. Understand? How you manage non-STEMI, how you manage STEMI. The first preference for STEMI for percutaneous coronary intervention. The second option, go for anticoagulant. Again go for anticoagulant. Okay, thank God the MI patient now still okay after non-STEMI or STEMI. This STEMI is mild, more chances for life. How about non-STEMI? How about this MI? This MI very severe, very severe. Okay, it's a transmural MI. How about this? It's just subendocardial MI. More chance for life after this. Okay. Okay. Now patient having the life, second life. Thank God. Patient survive from MI. What should give to patient? Again, start from A, B, C, D. Clear? Nitrate. Same thing. Calcium channel blocker. Same thing. Beta blocker. Same thing. And what? Anticoagulant. Anticoagulant. Add what? LDL drug. Add what? Hypertensive drug. Add what? Diabetes drug. Is a big list of drugs for MI. Understand? The things here, the new one, anticoagulant. These anticoagulant, heparin, these anticoagulant like patient on warfarin, anticoagulant, antiplatelet. Later we talk about this, okay, in the hematology section. Understand or not the management of MI and angina? Are you there?
Yes, sir.
About
Yes,
angina
sir.
and the MI, the key difference, you understand?
Yes.
Okay,
Angina.
if yes, then let me know. PCI used for what?
PCI for STEMI. STEMI.
STEMI, ST
Right.
elevation MI. Okay. If how much the time duration? Some books they write the standard. Some they also write 90 minutes maximum. Some they just say 30 minutes. Okay. If you late from 30 minutes, you're not able to perform. It's not easy. You just like you're rushing toward the hospital and now everything's available there. Everything is ready. It's now time is wasting. Yeah. So everything in CCU, in ICU, everything already prepared. They just, oh, if a patient has STEMI, must perform first PCI. Because if we want to save all myocardium, we want to save all myocardium. Understand? We want to save all myocardium. That's a PCI. We perform PCI. Clear? And the STEMI, if the time is gone, okay, if the time is gone, or if the facility is not available for STEMI, then your second option, you not choose first option, like not choose first option like anticoagulant, okay, not directly go for streptokinase, anticoagulant here, streptokinase, okay, and other we having heparin, and other we having warfarin, and other we having antiplatelet, antiplatelets. Okay, so these all are anticoagulants. They not allow the thrombus formation. Okay, so these anticoagulants we must add to important thing here. Yeah, MI. Understand? Must add to MI patient. If this patient belongs to non-STEMI, you perform PCI for non-STEMI. For non-STEMI, go for PCI.
No, sir.
Why? Why you wasting money of the patient? It's very expensive. No need to waste money of the patient. It's no need to perform PCI. Okay, just go for anticoagulants. Just go for anticoagulants, thrombolytics. Okay, break the thrombus, streptokinase for non-STEMI. Clear? For non-STEMI, just go for this. Okay, the patient having how many arteries there? One artery blocked, two artery blocked, three artery blocked. On the spot, you save the life of the patient. Yeah. Then the patient now stable within 1 week or 2 week, and now discharged from hospital. 1 week admit to hospital and then discharged. Now stable is okay. Every precaution you already guide to the patient. You explain everything to patient. You need heart surgery. You must need heart surgery. What type of heart surgery? We perform when the patient is stable. We need to perform angiography. Okay, angiography. We observe how many vessels included. Two vessel or three vessel. If three vessel disease, if three vessel disease, this patient as soon as must undergo coronary artery bypass graft. Coronary artery bypass graft. Okay, if the patient just the two vessel disease or one vessel disease, we just can give medications. Okay, this patient also just undergo angioplasties. Okay, prepare that vessel only. This patient also can undergo simple stent. Okay, stent, simple stent to keep open that vessel. Stent is also expensive procedure. The stenting of the vessel. If just two vessel or one vessel disease, the patient can undergo stenting. Okay. If the patient have the three vessel disease, three artery or main artery occluded, and if the patient having two vessels plus diabetes, then again go for this ED, coronary artery bypass graft. Okay. This for full management plan of full management plan of ischemic heart disease. Understand the medication every time you need to go for surgery. Okay, we perform angiography. We see how many vessels are involved, how many vessels are occluded. Okay, can go patient can need stenting or patient need cabbage, coronary artery bypass graft, coronary artery bypass. This decision done it depend upon the how many vessels. Okay, how many vessels. Two vessel disease or three. If three vessel disease, then directly go for cabbage. If two vessel disease only without diabetes, then go for stenting. If two vessel with diabetes, then go for cabbage. Okay, with a full management plan till surgery about ischemic heart disease. Okay, now come back to our medication group. Okay, I will see what are the side effects and these things, blah blah. Beta blocker, everyone know, yeah. What are the selective beta blockers? Selective beta blocker. Atenolol, atenolol. Selective beta blocker. Bisoprolol, selective beta blocker. Metoprolol, metoprolol. Must go for selective, okay? Bisoprolol, atenolol, metoprolol. Understand? Another selective, these all selective for beta 1. We have two another, also not forget this, this is also very important point about pindolol and acetbutalol, acetbutalol. Anything special about these two? These two are not complete blocker. These two are parts, also have activity like partial agonist. Never use in MI and angina. Keep in mind. If you give this pindolol and acetylbutalol in MI or angina patient, you are going to kill the person. Because these drugs, they having parts, you can go for hypertension. Okay, simple hypertension, you want beta blocker, you want to use pindolol. Okay, you can use pindolol, acetylbutalol. But for ischemic heart disease, these drugs are contraindicated. Pindolol and acetylbutalol never used in angina and MI. Keep in mind, it's very important, okay? Because these enzymes, they having these two drugs, they having sympathetic, intrinsic sympathetic activity. Intrinsic sympathetic activities mean they work like agonist also. Partial agonist. They're not complete blocker. They are blocker, but they also have stimulating property. Understand? They are blocker, but they also have little activity to stimulate. Don't take risk here. Understand? Don't take risk here. Not go for pindolol, not go for acetylbutalol. I have other option here: atenolol, bisoprolol, metoprolol. Okay, atenolol, bisoprolol, metoprolol. I can use these beta blockers, selective beta blocker. I am going for selective. Selective more good for heart. Okay, just act on heart. Just act on heart. So these are the beta blockers. Okay, next we go for calcium channel blockers. Calcium channel blocker. The concept about beta blocker done. Which beta blocker you go? Selective. Okay. Which one? Atenolol, bisoprolol, metoprolol. How about pindolol and acetobutol? These also selective, but the problem, these are partial agonists. These are partial agonists. Can you use in ischemic heart disease and angina patient? No. Must avoid pindolol and acetobutolol in angina and MI. Why? Because they have stimulating property. They have stimulating property. Understand? Okay, now move on. Calcium channel blocker. Calcium channel blocker, there are two groups. Calcium receptor present on cardiocytes. Calcium receptor also present on smooth muscle. Smooth muscle present in vessels. Yeah. So now the calcium channels, according to the channel, the calcium channel blocker could divide to two group, two main groups. They only act on heart, cardioselective. Only act on heart, cardioselective. They only act on vessel, vasoselective. Understand? They act on heart and they act on vessel. If they act on heart, what they're doing, they decrease the heart rate. If they act on vessel, what they're doing, vasodilation. Vasodilation. Okay. So calcium channel blocker, there are two family. Number one, dihydropyridine. Number one, vasoselective, dihydropyridine. Cardioselective, non, it's a chemical structure, okay? Non-dihydropyridine. It's a non-dihydropyridine. The cardioselective, we have two drugs. Number one, diltiazem, diltiazem, and verapamil, verapamil, diltiazem and verapamil. These are cardioselective. How about vasoselective? Big list. At last we having suffix here, dipene. At last, okay. At last are having suffix here, dipene, amlodipine,
Nemo.
nicar, nicardipine, nimodipine, familo,
Phenol.
familodipine. Many,
Dipene.
many there, okay. Familodipine, nicardipine, amlodipine, okay. Cevalipine, cevalipudine. So there are many names there. Okay, these are dipene, 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 dipene. Nimodipine is something special about nimodipine is not used for cardiac purpose. It's a best drug of choice for subarachnoid hemorrhage. Drug of choice for subarachnoid hemorrhage. Another nifedipine. Nifedipine. It's a drug of choice in hypertension in pregnancy. Okay, hypertension in pregnancy. Hypertension in pregnancy. Okay, amlodipine, nicardipine, nimodipine, famlodipine, nifedipine. So these are dipine family, okay? Dipine, 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 dipine. What they causing? They causing vaso. And when they causing vasodilation, what happen? The afterload will decrease, yeah? They cause vasodilation. If they cause vasodilation, total peripheral resistance will decrease, and blood pressure will get low because they causing vasodilation. So what they can cause? They can cause tachycardia. Tachycardia is good for angina? Of course not good. Must combine calcium channel. We can't use single therapy, okay? Beta blocker must be there. We combine beta blocker with calcium blocker. We combine nitrate with beta blocker. Okay, two common. Three drug was there, yeah? One beta blocker. Beta blocker combined with calcium channel blocker. Beta blocker combined with nitrate. Understand? So beta blocker, they directly act on heart, decrease the heart rate, yeah. And calcium channel blocker, they dilate the vessel. Understand? they dilate the vessel and reduce the resistance. So if they reduce the resistance, so demand by the heart is also decreased because the heart pumps very slowly. Okay. Another thing, because they dilate the vessel, they dilate every vessel. If they dilate every vessel, it means they also increase blood supply. Yeah, they also increase blood supply because they dilate every vessel. So they also dilate coronary vessel also. So if they dilate coronary vessel, this means the blood supply of the myocardium, ischemic myocardium will increase by using calcium blocker and nitrate. Nitrate also dilator, okay? Nitrate also dilator. So beta blocker we can't use in ischemic heart disease dilator alone, okay? Vasodilator if you use alone, what happens? Reflux tachycardia. Now here tachycardia is not good for angina or MI. We must block this tachycardia, yeah? So can't use alone, okay? You just give calcium blocker and not waiting for beta blocker, still they still not there. So you are a patient angina patient, you give calcium channel blocker as single therapy, you are killing patient again. Must combine beta blocker with calcium channel blocker. Must combine beta blocker with nitrate, okay? Must combine beta blocker with nitrate. Must combine beta blocker with calcium channel blocker. Clear? Okay, now again come back to calcium channel blocker. Calcium channel blocker, amlodipine, nicardipine, nimodipine, famlodipine. Okay, famlodipine, nifedipine. How about the cardioselective? The cardioselective was diltiazem, cardioselective, cardioselective, diltiazem, and another verapamil. Verapamil. These two calcium blockers, they directly act on heart. If you remember, calcium channel, nodal current production, action potential produced inside SA node, produced inside AV node, produced in conductor system totally depend upon calcium. Action potential, the plaque you produce inside the ventricle muscle also depend upon calcium. The calcium channel, slow channel present on myocardium also. The slow channel, these channel also present on conductive physiology. Yeah. So this calcium cardioselective calcium channel blocker, they block all calcium channel on conductive system. They block all calcium channel on myocardium. Understand? They block calcium channel on conductive system. They block calcium channel present on myocardium. So what they're doing, they decrease the one thing, they decrease the heart rate because they decrease the conductive property of the heart. Yeah. So they decrease the SA node firing, they decrease the AV node firing, and another thing, they also decrease force of contraction. Contraction depend upon calcium. If no calcium, it's mean the force of contraction of muscle decrease. If force of contraction decrease, how about the oxygen demand? Oxygen demand also. So diltiazem and verapamil, these drugs we can use for angina, but the preferable drug for angina patient, we also need vasodilation. They are vasoselective. So these drugs, the other uses we can use in ischemic heart disease. But the things here, listen here carefully. To decrease the heart rate, which drug you have here? Beta blocker. To decrease the drug directly acting on heart is your beta blocker, yeah, beta 1 blocker. Drug directly acting on heart is your beta blocker, yeah. So these drugs is not mostly preferable for here. Listen here, okay. For ischemic heart disease, we prefer because here we also need vasodilation, okay. So for ischemia, for angina, for MI, we prefer vasodilator along with beta blocker. Understand? For ischemic heart disease, we prefer drug vasodilator along with beta blocker. Nitrate vasodilator along with beta blocker. Calcium channel vasodilator along with beta blocker. So these are cardioselective. So cardioselective not frequently used for ischemic heart disease. Okay. So cardioselective we use for for what purpose? We use to decrease the heart rate if patient have any type of tachycardia. So diltiazem and verapamil act like anti-arrhythmic drug. They control the rhythm of the heart. Okay. In case of tachyarrhythmias, we will apply cardioselective calcium channel blocker. Cardioselective calcium channel blocker directly act on heart and decrease the heart rate. So we can use for if the patient having tachycardia, tachyarrhythmia, like ventricular tachycardia, SVT, okay. If have any issue in the node that node lead to tachycardia, we can apply calcium channel blocker cardioselective for arrhythmia. So cardioselective calcium channel blocker not preferably used for ischemic heart disease. Understand or not? Okay, this concept is important. So which calcium channel blocker you prefer for ischemic heart disease? Vasoselective. Vasoselective. Okay. So vasoselective amlodipine, nicardipine, nifedipine, nimodipine, famlodipine. Okay. This dipine family along with beta blocker. We use along with beta blockers. Clear or not? Okay. Diltiazem and verapamil. Diltiazem and verapamil we use for especially for arrhythmia. Especially for arrhythmia. Okay, especially for arrhythmia. And next come on vasoselective. Vasoselective. Vasoselective, for example, is your heart. Okay, they dilate the vessel. Vasoselective act on vessel is your heart, and then what happen here? Resistance here decrease, pressure here decrease. What happened? The signal going to brain, and brain then try to increase the heart rate. Okay, so vasoselective they increase the heart rate, and cardioselective they decrease the heart rate. Okay, not mix these two groups. Vasoselective they causing what? They causing it's a dipene family. They cause vasodilation, they causing reflex tachycardia. Reflex tachycardia. So we are not using here alone for ischemic heart disease. We're using in combination with beta blocker. Don't worry about the heart rate here. Heart rate is under control of beta blocker. Okay, heart rate the beta blocker can control the heart rate, and these drug vasoselective calcium channel blocker they will dilate the vessel. Okay, these drugs they will dilate the vessel, and the beta blocker they will control the rate. They will control the heart rate. Understand? So the vasoselective we combine with beta. We combine with beta blocker for ischemic heart disease. For ischemic heart disease. Till here clear? Till here done or not? Okay. Now we talk about the side effect of calcium channel blocker. Side effect of calcium channel blocker. If you think about cardioselective they can block the node, heart block, because cardioselective they're doing work. They block the conductive system. Yeah, they block the conductive system. They can block AV node. They can block AV block. Okay. Another side effect of cardioselective verapamil causing prolactin level will increase prolactin. Okay. Another side effect, constipation. They also block the GAT muscle, so that's why constipation. AV block prolactin and constipation. AV block prolactin and constipation. Clear? Another very important side effect here, gingival hyperplasia. If you remember any other drug causing gingival hyperplasia from CNS, last CNS last lecture.
Phenytoin.
Phenytoin, yes, good. Gingival hyperplasia also caused by calcium channel blocker. Which one? Especially verapamil. Okay, verapamil. Verapamil causing gingival hyperplasia. Verapamil causing gingival hyperplasia. The other calcium blocker, what they causing? The other calcium blocker, they decrease the blood pressure. So if your blood pressure low, what happened with you? You are dizzy. Yeah, you are dizziness. It's because your blood pressure low. Yeah, you're feeling dizziness. Another Your blood vessel dilated. What happened with skin? Flush. Skin become red because vasodilation. Yeah. Your blood vessel dilated. What happened with the foot? Because of gravity. It's this side. You can forget every side effect. Not forget gingival hyperplasia. Not forget this peripheral edema. Peripheral edema. Pedal edema. Better to write here pedal edema. Okay. Pedal. Foot swelling. Why foot swelling here? Because these drugs they causing vasodilation. What happened? Pooling of blood in the capillary and lead increased hydrostatic pressure. Now the liquid is coming out. Understand? Peripheral edema. Peripheral edema. Pedal edema. Peripheral or pedal edema, gingival hyperplasia is important side effect. These two side effects must keep in mind, okay? Gingival hyperplasia and pedal edema. And these side effects caused by Dipine family, okay? How about this? Cardioselective AV block, direct react on heart. Prolactin increase, gingival hyperplasia. These side effect belongs to verapamil and diltiazem. Okay, verapamil and diltiazem. And amlodipine, nicardipine, famlodipine, nimodipine, nifedipine. So all these drugs they can cause dizziness, they can cause flushing, they can cause peripheral or pedal edema. Peripheral or pedal edema. Till here clear? It's all about calcium blockers. All about calcium blockers. The last thing in ischemic heart disease, we need to use nitrates. This nitrate I must discuss the first because we firstly give nitrate to ischemic heart disease patients. Nitrate, what is the group of nitrate? Nitrate, nitroglycerine. Nitroglycerine, okay. And other we having the dinitrate. This is mononitrate, it's a dinitrate. 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 Isosorbide dinitrate, isosorbide mononitrate. Isosorbide dinitrate, isosorbide mononitrate, okay. Isosorbide dinitrate, number one nitro. This one is glycerol. The real name, the chemical formula, glycerol. Glycerol nitrate, okay. It's a glycerol nitrate. The glycerol nitrate. Isosorbide dinitrate, isosorbide mononitrate. Isosorbide, this one, another one. Nitroglycerin we only use in the form of, we also can apply patch, okay. We also can apply it, put under the tongue, sublingual. How about these two nitrates? When the patient, MI patient or unstable angina patient in hospital, now I must give IV. Okay, I must give IV. The nitrate I will explain in next class, inshallah, and we will continue with antiarrhythmic drug also. Okay, enough for today class. It's a very important lecture about ischemic heart disease here. Try to revise it. If you have any confusion, can ask me. Okay. If nitrate will continue tomorrow, inshallah. If you have any question, you can ask me. Okay, Assalamu alaikum.
Waalaikumsalam. Thank you, sir.
Allah Hafiz.
Allah
Allah
Hafiz.
Hafiz. See you inshallah
See you,
tomorrow.
sir.
Allah Hafiz.